Hello and welcome. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute, and I am so excited today to bring you this first of its kind series on as part of our Center for Liver Health Equity. We are focusing during Liver Cancer Awareness Month on issues that particularly affect the Asian American and Pacific Islander communities, and having experts in those fields and those communities tell us what we need to be doing as an organization, as a field, to better serve patients and physicians and researchers better from these perspectives. So many of you who are watching probably know, but I'm going to say it anyways, that liver cancer is the second leading cause of death for Asian American and Pacific Islanders. And so this is with such great urgency that we address these issues. We cannot achieve the goals of President Biden's cancer moonshot in the United States without making great strides in reducing levels of liver cancer. And to do that, we need to pay attention to what the Asian American and Pacific Islander community is telling us. And so without further ado, I will introduce our fantastic guests who I've been just so honored to have teach me and help me and support me in my advocacy growth over many years. Dr. Ruth He is the scientific lead of liver and biliary cancers right down the street from me at Georgetown University, part of MedStar and the Lombardi Cancer Center. Dr. Robert Wong is a little further away from me, but we feel very connected virtually several times. And his research from Stanford University in Palo Alto, California, has really given us such a strong foundation in which to work. And last but not least, I have Dr. Na Li, who is a physician and clinical associate professor of internal medicine at Ohio State University. And so we have the entire country covered, which I think is very important. And it's important too, as well, to our global community, since we know there are so many from a variety of Asian countries who have come to the United States and are living in DC, California, in the Midwest, and all of these areas that we serve. And so those issues and bridging to our partners in Asia is also very important to us. So with that, perhaps I will throw the first question to Dr. He. What are the drivers of liver cancer in Asian and Asian American populations? Why is it so prevalent and so deadly?
So I think for Asian and Asian Americans, I can think of the risk factors, the top risk factors. One is HBV infection, prior HBV infection, and also the rising risk factors of NASH, non-alcohol steatohepatitis as part of the metabolic syndrome. I think both we can observe those coming as important risk factors for Asian and Asian Americans for their liver health.
Fantastic. So Dr. Wong, your research has just been so fundamental to understanding this field. What can we learn from how Asia approaches liver disease and liver cancer? I've always been struck by how more advanced their advocacy, their research, their education is. What are we missing out in the United States? What are we not seeing as we look at Asian Americans and their relationship to liver disease?
Yeah, thanks, Donna, for hosting this really important session during Liver Cancer Awareness Month. And I think, as you said, liver cancer, especially for the Asian Pacific Islander community, is a huge clinical burden. And as Dr. He said, one of the main drivers, especially in Asian communities, is hepatitis B virus. And we see this in some of the countries outside of the U.S., as you alluded to, particularly in China, Taiwan, Korea, where the prevalence of hepatitis B and subsequently, the prevalence of Hep B associated HCC is much higher, incidence, prevalence, burden of disease. And as you alluded to, it's important to look at what these other countries have done, both in terms of screening and treating HCC, but also even looking further up in the cascade of care, their approach to hepatitis B screening, vaccination, and learn from those lessons and how we can actually implement that in the US. In the US, hepatitis B is not as prevalent as some of these other countries, but it's still very important. Some of the recent data, from our group really showed that prevalence of Hep B can be as high as 2.4 million in the US, which is not a small burden. And adding to that concern is that still a large proportion of patients with hepatitis B are not screened, unaware, not diagnosed. And I think what we can learn from some of these countries is how to implement more effective education, advocacy, implementation science into screen for hepatitis B, linkage to care. And I'm so excited that, in the US recently, earlier this year, that the ACIP recommended universal Hep B vaccines for those 18 to 60. And, that is a big step towards trying to address the hepatitis B associated HCC in the US. And I think further efforts on thinking about how we can best implement those recommendations to vaccinate, but also not forget that vaccination should be linked with screening. And hopefully sometime this year or early next year, there will be some revised recommendations about screening for hepatitis B too. And I think, things that GLI and other major societies and public health advocates can think about is how do we implement these recommendations so we can better identify Hep B, link them together, and ultimately the goal of preventing HCC in these high-risk communities.
Absolutely. With 70% of liver cancers being preventable, moving all the way back to vaccination for hepatitis B, working in hepatitis B cures, implementing hepatitis C cures, resolving NASH is really the best way to be able to address liver cancer holistically. Dr. Lee, accessing care I'll give you a chance to take a sip. Accessing care is not as easy as some people makes it sound. Just go get your vaccine. Just go get tested. Just go get screened. So what are some of the barriers and biases that Asian and Pacific Island patients face trying to access care?
I think as Dr. He and Dr. Wong mentioned, so the liver disease and especially with the liver cancer, the primary risk for Asian and Asian American people are hepatitis B. So the barriers I would say for because itself the hepatitis B is in my opinion I think it's a preventable disease. So with the vaccination that we have, it's a very effective way that we can reduce the hepatitis B infection. I think this is particularly important for babies and in young children, as they have a higher risk to develop chronic liver disease when they get infected compared to adults. So I think that to advocate in terms of for the public awareness about the disease and also the strategy to make them understand that the hepatitis B can be prevented and to get the or like the related liver cancer can be prevented. I think that is very important. So one of the barriers I feel like in just from the cultural background that in terms of the Asian and Asian Americans, I think so it's I think for for some reason there's we tend to be less accepting of screening for disease, given absence of symptoms. So it's kind of like when when I was a little, I think that I'm originally from China, so that people don't just not go to like routinely do kind of like the annual physicals or something like that. And of course, then hepatitis B, because of the high prevalence, so there's national policy has made to make it mandatory for the screening for the students. And also like kind of like a national strategy, and also with the national vaccination the policy, this has successfully reduced the incidence of the hepatitis B infection. So I think that like in Taiwan or China, so their prevalence is not as high as like a high endemic area, and it started to kind of like drop to the moderate the area now, so which is very successful. I think that's kind of like the policy. It's a health care policy is very important. So in the United States, I think that we did have this hepatitis B vaccination, I think launched like in 1999. So, and a lot of effort has made so that with group, and I kind of like joined with a national hepatitis B task force as well. So a lot of like effort has been made from all different levels, from the physician, the community people, and also like of course in an important part at the GLI, other organizations. So these are, I think this is what we kind of like have achieved. So I think we do have good news, because recently their study have shown that the liver related liver cancer has kind of like the incidence started to drop. Of course, in the United States, the most common thing is related to the hepatitis C, and now we have more effective hepatitis C treatment. So that's kind of like one of the major driving force for the drop of the liver cancer incidence. But hepatitis B also show there's a drop of the hepatitis B related liver cancer risk. So I think that's we should kind of like be proud of ourselves, and we did make a difference for our care in the United States and related to the hepatitis B. So, and also liver cancer. So this is very important. But in terms overall, I think there's still barriers, and there's still things that we can improve, and to go to the community. That's one of the things I'm trying to work hard towards to get how we can get the people in the community to get their attention, to make sure they understand what is kind of like the significance that we do. Because we will need to bring the whole, not only the physicians or the patients we see in the clinic, and more importantly, how we can actually get the whole community to work together.
I have a point I want to make for Dr. Wang and Dr. Lee's comments. So as a medical oncologist, I see at the other end. So I do see patients are diagnosed with advanced stage liver cancer. And so a lot of times patient family will ask me, or I will ask myself, how was this missed? How was this not found very at early stage of disease? And I found like in some patients, they are not screened for hepatitis. So they have had primary care for a long time. They have access to medical care, but that was not screened. I'm glad now there's more effort to educate the patients and the first line doctor in primary care to screen for hepatitis B and C infection in the Asian Pacific Islanders. Second is when patient is found to do not have active HBV or has been treated for HBV and lost follow-up. And they have initial screening of cancer at the very beginning was cleared. But then I think the patients or public needs to be educated that that's an ongoing effort. So if you've had a history of HBV infection, and you cannot forget about it when the first screening for cancer is negative.
Mm-hmm.
And even you change physician, that history, you have to take it to the next physician. And then, so we've had patients, initial screening all good, but then a couple of years later, come back to the oncologist with cancer. So I think it's important to educate, to make it aware, make the public aware of the importance of continuing care.
Absolutely. You know, it seems to me that there are some gaps. You know, there's a fabulous birth dose campaigns. There's now the new campaigns for 18 to 60. There are, but my age group, I think, got a little left out in the vaccination. But I was screened prior to starting on a biologic for my IBD, and have served on guidelines to make sure that prior to starting chemotherapy, that people are screening for hepatitis B. And so there are all these different inflection points where someone can be, identified, and their opportunities to sort of catch them up on vaccination if they weren't originally. So I want to make sure that people know about all these options and all these different parts of the healthcare system, and different doctors know that they need to be part of this as well. So I think that's an important point. Dr. Wong, I wanted to ask you about veterans populations as well. How does liver care work at the VA?
Yeah, thanks for asking that. You know, the nice thing about the VA health system is, you know, it's a true national healthcare system. You know, something that we've really strived for in the U.S. You know, some other countries have something similar, and I think the benefit of this is that care, for the most part, is very integrated. You go across the country. There's several VA centers, hospitals, VA health systems. You can get care. Your records and electronic health records are accessible in a true national healthcare system. So I think the what the VA does well, and it could be a model for some other health systems and, you know, in the U.S. to try and adopt, is integrated care. I mean, it's truly integrated care. It's multidisciplinary care. The other thing that you know, related to hepatitis and HC liver cancer that the VA has done extremely well is look at the trends, that the successes that they have done with hepatitis C. And there's not a lot of Hep B in the VA population just because of demographics, but hepatitis C is probably much more prevalent. And if you look back at the implementation of screening, linkage to care, and access to treatment, and achieving Hep C cure that has been achieved within the VA population, it's just amazing how quickly they were able to adopt and implement this treatment to reduce Hep C burden. And many have pointed to the VA's, the VA as a model in how to quickly access and implement hepatitis C care. Related to HCC, you know, this is something that I've also lauded and sort of shared with different health systems. The VA, because it's so well integrated, they're able to develop these, we call it dashboards. So within each geographic region, we have a dashboard where we capture all patients with cirrhosis.
Wow.
And the nice thing about this is someone is actively managing this dashboard, meaning they go through it, they make sure these patients are getting follow-up, getting clinic visits, and then most importantly and relevant to this, making sure they're getting their Q6-month HCC screening and surveillance. And you know, that's something that seems so simple to be able to do it, but it's so difficult to implement in in my opinion, a relatively fragmented health system that the U.S. is. So I think one potential way to try to improve that gap from identifying who needs screening and getting them to screening is to somehow develop some mechanism, whether it's using EHR, using AI type methods to kind of identify and automatically order HCC screening. We need to do something different because, as you know, some of the literature shows that HCC screening and appropriate HCC screening in patients with cirrhosis still is dismal. It's only 30-40% at most. So more than half of people are not getting HCC screening and surveillance when they need it. And what is the result of that? Well, the SEER, the National Cancer Institute's cancer database, still shows that for HCC, 5-year survival is 30% or less. So we still have a lot of work to do with linkage to care.
That's absolutely true. I remember a conversation with a very large academic center with an innovation hub, and we had asked the innovation hub to try to just identify the patients, already within their system with a diagnosed liver disease, to send them an email alert for their 6-month screening. And they were like, this is so hard. They're everywhere. Some of them are in hepatology, some are in oncology, I was like, yes, but we're here to do hard things, right? That's why you're an innovation hub. And we're only asking within a very well-funded, very, well put together system for patients who are already identified. We hadn't yet asked to go out into the community and find new patients. Here were patients that were already in their EHR. And so I think that that idea of a dashboard is something that we really should push at a very minimum for patients who already have an identified liver disease, who are already in the system. If we can't do that minimum, it's harder to build on different things.
Yeah, and part of it, just add one minor thing is what sometimes when I think about these gaps in care, I take a step back and I say, what are the drivers of care?
Right.
What are the drivers of action? How can you incentivize people to do it? And unfortunately, a lot of it's financial. And then another thing is a quality measure. HCC screening is recommended, but it's not a measured, quality metric that people are, being tracked. So I know AASLD has published, recommendations for cirrhosis care. And one thing that may help is to push this along and actually make this a quality metric. And then, unfortunately or fortunately, this will really force people to pay attention to this.
Absolutely. And these are the types of ideas, the really specific things that, I'm listening for, that my team is listening for how GLI can be helpful. I heard the other day, I was sitting next to chief medical officer for a health system, and we were talking about the drivers for different things, whether it's diversity in clinical trials or other things. And he said accreditation. And we do this type of research, we do these certain things for accreditation. And I was like, oh, that's fascinating. I wouldn't have thought about that as an advocate. Quality measures as a driver. These are so important for us in advocacy to learn, so we know what is the most useful mechanism to be able to push forward. I want to talk about clinical trials with you, Dr. He, and also I think, Dr. Lee, this plays into some of your work as well. Several of the populations that we work with and that we talk with about clinical trials have different barriers, but often language is not one of them. We talked about navigation in a prior roundtable, but what is the role of interpreters and the lack of interpreters in a hospital for patients to access care and certainly to understand how to participate in clinical research? So Dr. He, what are you seeing and what would you like to see?
Yeah, you can imagine, so to enroll patients under a clinical trial, it's challenging to physician in terms of time investment in a busy clinical schedule. Now you want to add the language barrier to it, and some clinical study, and it will take a lot of resource to translate the whole ICF, the consent form. Other study will allow shorter consent form, and with the assistance of a live interpreter. And so you can see there is no unique guideline how to do this. I think it does affect enrolling patients on clinical trials when there's when the physicians and also the study coordinator in the very busy schedule and try to really get patients on. When you get patients on and managing the possible side effects and have reports to the physicians on time, and also can be impacted by the language barrier. So for sure, I think right now many institute, and we're all trying to put together, like provide a lot of support, try to encourage enrollment of patients speak another language on the clinical study, but it's still unmet need, and I think more help is needed. So then we could try to get more patients on the clinical trial. There's always HCC is a large health problem in Asia. Compared to the US. So when you compare the data from Asia and to the US, sometimes you wonder how much disparity in terms of that's specific for patients and not just the care system. So it is crucial to really enroll a lot of Asian patients on the study to represent this population in the US to observe the efficacy and safety in Asian patients live in the U.S. So it's very important, and I think there's an unmet need.
Excellent, Dr. Lee. How do you work with patients? How do you build trust? And particularly, you're working in NASH, something most people have never heard about in the first place, and so how do you convince people to do something that they wouldn't normally do about a disease they've never heard of in the first place, and to spend more time with the healthcare system than they ever thought they wanted to?
Yeah, so I think this is a kind of like ongoing thing. So because where I stayed in Columbus, Ohio, and in Dublin is a city that we have a relatively large Asian population. So in Dublin City, 20% of the Asian population there. So that we kind of like have like a diverse the faculty as well. And so many of our patients. So I think this is I think it's a human nature that when you get connected to the people who have a similar cultural background and you feel more comfortable. So I do carry over a lot of like Asian and Asian Americans in my clinic regarding especially for GI issues or liver disease, hepatitis B, and all these things. So I think that's kind of like it's just like the feel that it's easier to build the trustworthy patient doctor relationship. So I do want to kind of like echo what the doctor he said. So for the clinical trials, because I run I'm kind of like the PI in quite a few clinical trials on NASH, which is not it's even though it's kind of like become a global the phenomenon of this condition, but I think it's a more predominantly still in the kind of like Western countries, especially with the fibrosis and everything. So many of the Asian people they are not aware of the fatty liver. So and it's similar to other conditions because relatively they often don't have that many metabolic risk factors compared to the white American people here. But it is intentional kind of like potential issues in the future, and we may actually see the change in the near future regarding how this NASH or the fatty liver disease affect the Asian population as well. Because some of my patients do have like the Asian and Asian Americans do have fatty liver disease. So that's something kind of like we monitor. In many people's mind or the impatient's like impression that fatty liver is nothing. It's a benign. It's a condition. It's just a fat there. So there's nothing that it does to the liver. So they care more about the hepatitis B, which is kind of like they know more, and since this relatively more big issue in Asian countries. So the clinical trials that we have for NASH, and definitely that they are getting the minority group, like the racial or ethnic groups, and it's not ideal. That's involved with the consent issue that you need a different language for the consent for them to sign, and also the other thing is for the communication, because the patients needs to have regular visits and make sure they are safe. So those are potential barriers like we have. So I would say for for this kind of like trials, and definitely it's not entirely representative of the whole ethnic groups, and so this is one of the issue, and many studies have shown that for the minority, the ethnic groups, and it's kind of like underrepresented in many of the clinical trials. So for hepatitis B trial, which is probably different, it's just because the prevalence of the disease in the Asian and Asian Americans. So that's kind of like the different thing. But I think overall, there's still a lot of things, and we can improve in terms of the universal like liver disease that can include more people from different racial and ethnic groups, and so become more representative. So we can disaggregate of this data, and for each specific group, and then to get a better recognition of the disease itself, and how we actually to achieve the health equity, and also for the kind of like universal care for the entire the people, not just like on one part. Yeah, so that's kind of like how I feel when I see my patients in the clinic. So definitely there are more things that we can improve.
You know, I've seen a lot of data out of Singapore, for example, on NASH in lean individuals, and it reminded me of the same way that when I was learning about diabetes and looking for diabetes at lower body mass index, even with all the limitations of body mass index, but looking at lower body mass index in Asian population, so that you wouldn't miss a lot of people using a model that was created for a different population and a different sort of body size. So Dr. Wong, you are really great at showing about the gaps in data in rare liver diseases and in other types. And so what are some of the gaps in research? What are we not finding because maybe we're not looking for it, or because we're making certain assumptions about who already has some disease before it's well characterized? So what can we do about gaps in research?
Yeah, thank you for that. And I think specifically for liver cancer and liver cancer in Asian and Asian Pacific Islanders, I think there are several areas where there are gaps in the literature where we can contribute to. First, as we alluded to a little bit earlier, is within the hepatitis B cascade of care. We have excellent antivirals, not a cure, but we have antivirals that can suppress. But still, I think there are existing gaps in how do we understand what are the drivers of disparities in linkage to care, access to treatment, access to screening, and more specifically, are those drivers a patient issue, meaning not patient education, lack of awareness,
Mhm.
lack of understanding about severe? Is it a provider issue that we are not aware? We're not screening. We don't know who needs to be screened or who needs to be linked, or when and how people need to be treated. Or as a bigger picture, is it a health system issue? Is
Mhm.
it that patients cannot get access to specialty care, cannot get
Mhm.
access to ultrasound or CT or diagnostic imaging? And I think that's one thing that, if we say that, yeah, there's disparities in care, but I think that's one thing we need to look more closely at is what are the drivers of disparities? And more
Mhm.
specifically, how do these different aspects of disparities interact with each other and synergize with each other to exacerbate disparities? Because it's not one thing. And I think disparities in care are multifactorial, and any approach to address disparities has to be a multifaceted approach that targets each of these aspects. Another area that I think you mentioned a little bit earlier, and Dr. Lee also mentioned, is the underappreciation of fatty liver disease among Asian populations. And I deliberately use the term vaguely fatty liver
Mhm.
because this fatty liver can be alcohol related fatty liver,
Mhm.
or what I like to call now, I know there's a debate, but I like to call it metabolic fatty liver. And I think both of these are very
Mhm.
important and I would say under recognized in Asian populations. And especially, as you say, this concept of body mass index is designed in a primarily non-Hispanic white population. And
Mhm.
that's why, BMI cutoffs for Asian populations are lower.
Right.
And we see in studies from China, we see in these big studies from Hong Kong that fatty liver actually is very highly prevalent among Asian
Mhm.
populations. And this concept of metabolic syndrome and lean fatty liver is even more important because there are
Mhm.
existing literature that show that lean fatty liver actually has more severe disease at presentation and more
Right.
aggressive natural history. We don't know why. There's probably some genetic or other comorbidities or confounding factors that contribute to it. But still, I think it highlights the fact that there needs to be better awareness of fatty liver among Asian populations. And then finally, alcohol.
Mhm.
Especially during the pandemic, we saw this surge in alcohol use
Yeah.
disorder, and now we're seeing the downstream effects of
Mhm.
alcohol-related liver disease. This is across populations, and I think
Mhm.
that oftentimes we don't think of this in Asian populations for a variety of reasons. But I think more and more it's something we should pay more attention to because it is an important liver disease burden in this population as well.
I think that's huge. I think that's so helpful. I think that we, as a public and as a medical community, and even as patient advocacy organizations, sometimes we have an idea of, you know, which diseases affect what type of person. And it's one of the things that I've tried to dispel in our work in the Global Liver Institute. Because everyone has a liver, and so everyone is at risk of some or all types of liver disease, and so it needs to be the focus for everyone. And I think that the sort of universality of liver disease, like heart disease or things that affect the brain, is something that we need to um, really work on. And I think that there's an opportunity if someone is getting, if there's already a system, for example, to be screened and treated for hepatitis B, to screen them for for hepatitis C, to screen them for hepatitis B, and NASH as well, as that becomes easier to have a serum marker screening or a or imaging that could be put in a mobile van increasingly. So I think there's less and less of an excuse not to do sort of multi-liver or whole liver health, rather, to put it a positive way, whole liver health screening for everyone, and not assume that someone might only have some type of disease and may only and certainly couldn't possibly have another type of disease. I think we're missing a lot of people by doing it that way.
Yeah,
Dr.
I think
Lee.
clinically, what we see actually, so often if we go for the liver biopsies,
Mm-hmm.
Often we see the people have multiple issues going
Mm-hmm.
on. So even initially, the liver biopsy may meant for patients, for example, have autoimmune hepatitis,
Mm-hmm.
and then they come back with the autoimmune hepatitis with NASH
Mm-hmm.
together. So altogether, I think the more or less, and it's we see like the fatty liver more and more, and in
Mm-hmm.
combined with other conditions, and have like there's so far like many studies have shown that you have like when you have concurrent conditions going on with the liver, that the liver disease tends to progress faster. So definitely those are the patients, including the hepatitis B and hepatitis C,
Mm-hmm.
alcohol-related liver issues. So they kind of like many conditions, especially with this fatty liver disease, that can progress faster. I think there's so if there's multiple insults to the liver, so it's kind of like there's the process and or the underlying pathogenesis kind of like triggered with the more like a faster progression. So I think this is a clinically, I think that as Dr. Wong said, so this is also involves with the education, like the gaps that we have. So the education is not necessarily just about the patient. Sometimes it's actually among the clinicians as
Mm-hmm.
well. So many of our like the primary care physicians, also the oncologists, and prior to they started with the chemotherapy or any other the specialties that use the immunosuppressants for whatever reason. So the hepatitis B should kind of like be screened. So a lot of these situations needs to be educated from all kinds of like levels in this healthcare system, and of course, and then to follow the standard care with the guidelines, that to because it's more like the reason is guideline, not necessarily meaning that that's what the physicians need to do, because it's meant for the guidance, but those guidelines is generated because of there's good evidence to support that. So that there's for example, this liver cancer screening, there's a kind of like a good data to support and in what type of the population and situations and the patients needed to have more close surveillance, such as that there's a specific with different kinds of the like the liver disease with the hepatitis B, and of course the cirrhosis is more straightforward and clear cut. But those are kind of like the things, and but the overall national liver cancer surveillance is kind of like low. So this is something that we should improve. But I said like one of the things I kind of like I feel like in Asian and all Asian American population, this is I kind of like tends to people have this kind of like not a very very probably not take that in that the high priority in terms of this of the surveillance or the screening, because it does not, you don't have experienced any symptoms and then they feel fine and they have like a no flu, and then it's harder for them to say, okay, I need to go to the doctors on a regular basis and to have the ultrasound or any liver imaging done on a regular basis. So that's something that I think we needed to improve in terms of how we can better educate our patient, emphasize what's the clinical significance for that.
Or, I mean, what would resonate with people if we brought, FibroScan machines or other things into, CVS's or Walmart's or Target's or libraries or community centers? What do you think would help, resonate with people and put the care in the flow of their lives?
I think that's kind of like the great kind of ideas. So with the FibroScan, we use the FibroScan a lot. That for our patients, not just for NASH, and we use for pretty much for everybody to kind of like assess the hepatic, like the liver scarring, fibrosis. So this is actually, I try to do this. This is talking about like a community is how we can actually improve the public awareness about the liver disease. So the one time we have every year before the COVID pandemic, of course, that have this like Asian festival that we get a lot of like, it draws a lot of attention in the community, not necessarily just the Asian population. So a lot of like attendees. So we use that opportunity to get the like the health affair as well, and then to one of the part is a specific focus on the hepatitis B, and so we our institute did previously just screening the patients, whoever attended there. If they think they have a family, if they're immigrants, we offer for the hepatitis B screening test, which is free. Of course, we get the CDC grant for that. So that kind of like helps significantly capture a lot of patients who with unknown like hepatitis B and diagnosed. Of course, they don't have any symptoms. So that is very important. So one time I brought a portable FibroScan machine to the festival, kind of like to kind of like educate what the liver disease is and all the fatty liver. But is to that is kind of like the people are fatty liver still relatively not a common kind of like the disease knowledge to the public. So not a lot of people don't even know what it is. So that the but to having a scan, I think that patients are more willing to say, okay, I got it. I can check how my liver is because I don't have the symptoms, but this is a free test. I'm more willing to see if I have any significant liver disease. So I think that if we have some sort of the point of care, of course, this type of the test is if we become more and more available, even in the primary care, like the setting, or in the health fair, I think it will be helpful. But of course, it needs a little bit of physician interpretation of the results, and to make sure that it's appropriate for the patient, because itself it does have limitations. So we don't want to interpret the wrong result and get the wrong conclusion. So, but I think from the patient standpoint, if we are able to provide some sort of the simple and easy accessible test through either blood test or a scan, something like that, I think they are more willing to proceed with the kind of like to follow with the recommendations, and they're more easier to get that concept. And that's something I probably needed to pay attention. My families, my friends, and probably needed to pay attention to about their liver health as well.
Right. Dr. He, jump in, please.
Comment you want to make
Yes.
is I think in the community, some patients have the stereotype of patients with liver disease.
Right.
And they think about viral hepatitis, and they say, well, I'm clean. I don't have viral hepatitis. I don't drink, so my risk is low. I think that we need to educate the public that now there are a lot of patients who don't have that stereotype and still have a liver health issue. So that's one point I want to make. The other is, I think even for clinician, I think our understanding about how fatty liver disease contribute to HCC and how to do surveillance in patients without cirrhosis, just with fatty liver disease, and how those patients being followed for cancer screening. I don't think it's a clear answered question. I don't think we have a clean answer. I think that's evolving, and even in the field. So I think if patient has cirrhosis, we know the path is clear, and those patients need to have AACLD recommended cancer screening. And actually now, if you look at the patients from the community, more and more people are doing the surveillance, HCC surveillance with ultrasound if patient has cirrhosis. The problem is, prior to cirrhosis, they have fat liver. We also have seen HCC patients do not have, they just have fatty liver as the etiology, and they do not have cirrhosis. I think we're still trying, I think there's a research area. We try to understand what's the additional risk factors or genetic predisposition in those patients with non-cirrhosis, fatty liver, and develop HCC.
I think it's very important point that you raised to be able to properly stage and characterize patients so that we can do additional research on, who are the fast progressors and slow progressors, and also be able to match the treatment for people at their various stages of diseases, because it's not just like, well, wait till they have cirrhosis and then start doing all of these things. We need to be able to have interventions, whether it's connection to a dietitian or bariatric surgery or what have you, at the different stages and patient profiles and characteristics. And so I think what you're saying is very important. And Dr. Wong, you're nodding, so I'll let you speak here and give your thoughts on sort of, characterizing, patients clinically, and being able to, support them with the right treatment plans.
Yeah, this is so lovely how fluid and dynamic this conversation is flowing. And I think you guys highlight some really important points. And I think to add on to that, I think is, just from a big picture, and this is something where I think Global Liver Institute can work on too, is I think the patient stigma aspect of fatty liver, and actually for all of these diseases, and how we can try to reframe this as not liver disease, but rather we're trying to promote liver health.
Right.
And when we're doing all this screening and comprehensive liver care, whether it's trying for early identification of fatty liver, hopefully soon screening and then vaccinating for hepatitis B, assessing for alcohol. Sure, in the back of our minds as clinicians, we're sort of ingrained to say we're screening out disease or ruling out disease. But I think to better frame it for patients, to kind of reduce the stigma of disease and high risk, we should really reframe and say, we're doing these things to try to promote your liver health. And we're trying to identify these things so we can prevent, complications, and really emphasize the liver health component, what we can do as clinicians and as health systems, and really from a public health standpoint, how we can promote liver health across populations. And one thing that you said earlier that really resonated with me is, and I think what Dr. He said too, is to dispel these stereotypes of disease. When we say NASH, I think probably most of us, if not all of us here, will say, oh, okay, Hispanic population. But really, we need to dispel that so we don't find ourselves subject to this kind of framing bias, because by doing that, we introduce stigma. But flip it the other way, by doing that, we actually, blindside ourselves from these other populations that we may not be highlighting. So I think rebranding it as liver health and also dispelling these stereotypes, I think, are two sort of important aspects from a patient advocacy standpoint that we can do a lot better.
Absolutely. That has been our mission from the beginning, to be able to focus on liver health. And we're so excited to have launched our Liver Health is Public Health campaign, and continuing to get support and endorsements for that. But it's also why my Instagram is full of glossy pictures, because this is what 28 years post liver transplant could look like if everything goes right. It's why I have liver lady license plate on a hepatic burgundy car. I'm just doing everything I can to reposition the liver. I'll tell a funny story. I had the opportunity to meet the designer, Donna Karen. And I usually, when I tell people I'm with the Global Liver Institute, they're like, the what? I'm like, liver, like liver. Or they'll, get some funny look on their face, or, even Ambassador Brinker was like, oh my. And I was like, wait, you said, just you did breast cancer, and so she's like, how can I help you? She was so lovely. But I ran into Donna Karen, and her response was so different. She's like, oh, well, of course, the liver is so important. And she went on waxing eloquent about why. And I was like, oh, if I didn't already love you, I love you so much. But I think that is we need to sort of break out of our silos, and we need to, sort of throw off the stigma that, as I talk further with people, I start to hear stories. Oh, well, my uncle had liver cancer. Oh, my friend had a transplant. Oh, my sister had hepatitis, and all of these stories come out with just a little prompting, but we need to create sort of the safe space for people to come forward. I think that then will really, fuel our advocacy. One of the things that I learned and had access to when I was, when I started a lot of this years ago, working in hepatitis B and working in Asian communities, was the fact that because it did affect infants, pregnant women and infants, and it did in fact grandparents, that there was an opportunity to really dispel a lot of stigma. Because of course, the little baby, it wasn't at fault. Of course, your grandfather is somebody you respect. And so you have to respect and want to give resources and focus on this disease if it's really something that anybody that you care about in your entire family could have. Then how could you possibly, devalue the importance of this? And I think that has to be central to all of our conversations about liver disease moving forward, and why I'm so grateful for the work that you all do.
Donna, I actually want to give you a special thank for all what you're doing. So I have been following the GLI for quite a few years because of the MASH I do. So I think that you have been leading a phenomenon like the programs on the liver health, and especially with the NASH. So that is very encouraging for us as well. That is, I think the GLI. So it's a very unique and important organization, which is connect the clinicians and community and or like the policymakers. So it's very important because as a clinician, we see the patients in the clinic office, right? So we cannot, the outside of the community is more our families and friends, but it's kind of like we don't carry out our work back to the community. But in the reality is in order to deliver a good health care and complete health care, we needed to get everybody together. And so the community, how we can connect we needed someone bridging this, the system, connected every person together. So this is why I have kind of like seeing you on many of the liver meetings, of course, so that to connect the different parts in terms of advocates for things that is important for our patients regarding the liver issues, how we can make the law makers and to understand what we need, what we're trying to address, and how we can make a difference on our patients. I think that's very, very important, carries great impact on our healthcare. So I do really want to say thank you. And of course, these things are not easy, as you probably know better than us, in terms of like how you can get the thing working. So that we're talking about, we are why we're now screening everybody, the patients that involves with the cost, whether it's cost effective, and if there's any. If everybody have the equal access to certain healthcare, so it's the whole system is not simple, it's not straightforward and from A to B. So it's always tangled together, have different parts involved, and so I think this is why the organization such as the GLI is very important to kind of like connect all the dots together to make sure everybody is working together and find a good points that can have a good balance between the clinical care and between the overall health and also the financial, of course, the cost is always an issue that we face, no matter where we go.
I thank you for that. We feel so seen. I love the term harmonization. I think that's absolutely what we're trying to do, to make sure that everyone is working well together, that there's no duplication, and to the pricing and the policy issues to support all of this, of the optimal clinical and community workflow that we've been discussing. I'm really excited that we have a new vice president of policy, Daniel Naum, who comes from a fantastic background, as he's a pharmacist and attorney, and has spent a lot of time in the payer community. So really being able to bring in more resources to understand that financial navigation piece for all the parts, from the initial insurance access to accessing primary care through oncology. And Dr. He, if I could come back around to you, if you had your ideal oncology practice, and you had your nurse navigators and social workers and peer mentors and interpreters and a multidisciplinary tumor board, what would cancer care look like? You have a lot more therapies and tools to work with for patients. And so if we were able to support patients, all the way to you, what would care look like for them?
I think the outcome would be very much improved for the following reasons. So, in the last 5 years, the treatment for advanced liver cancer sort of has changed significantly. That landscape is still evolving. And so we've made very big, large progress in terms of like having more treatment options, the immunotherapy combinations that increase response rate and prolong the survival of patients. And that it's it's an ongoing effort, and there are a lot more novel combination therapy being evaluated in HCC. And so we would like to really move this field forward quicker. We would like to have the support to enroll more patients with different ethnic background to get on study and represent the biology of tumor from those patients. And so, and then while they're on the clinical study, they can be well supported. I want to give you an example. Our wonderful social worker actually received a grant and to provide transportations. There's a Ubers. It's small funding, but that has helped so many patients to get for treatment. And so you can see that will increase the efficacy of the treatment with novel, innovative treatments, and it's safer for patients because then patient can report to the physicians effectively, and then we can take action and provide support to those patients. And right now, there are still patients who have difficulty communicating, and then they don't get the treatment to overcome the side effects of treatment on time. So I think with additional support, we will have treatment that provide better outcome and also better safety profile to those patients.
That made me think about, how I learned what palliative care really was and meant, and how valuable it can be to not just the patient, but to families as a whole. And so maybe if I could ask, each of you, maybe starting with Dr. Wong, is palliative care an option? And maybe can you explain it so people understand, all that it offers, and do families feel comfortable reaching out for palliative care?
Yeah, thank you for bringing this up. Palliative care in liver disease, and particularly in cirrhosis care, is an area of hot topic for research now. And the reason I say that is that a lot of times in patients with cirrhosis, palliative care is sort of seen as a transition to death, unfortunately. And in most cases, it is. But it's sort of, we have to rethink about the involvement of palliative care, and again, sort of shifting the framework. I think the few gaps in care that exist for palliative services in liver disease, one, there's several studies showing that patients with cirrhosis are not getting referred for or utilizing palliative care. And in those studies that sort of compared patients that do or don't, actually show that those patients that get palliative care live longer, have
Mm-hmm.
better quality of life, which is really important, especially with end-stage liver
Mm-hmm.
disease. And really the patient satisfaction and family satisfaction, because
Right.
it's oftentimes for these patients, it's not just the patient, but it's the entire caregiver support system that really
Right.
is trying to deal with what is going on. Um, so one, I think a lot of places have it, but underutilizing it for liver disease patients. Reasons are not clear. There's studies looking at utilization and also surveys and sort of trying to assess what are the drivers of underutilization.
Mm-hmm.
I think part of the problem is the sort of the misconception that you either choose treatment or you choose palliative care, but it's not true. And the I think a lot of the concern for providers and patients is when you choose palliative care, you're sort of in a weird way saying you're giving up, but it's not. And I think palliative care, as all of us here know, can provide a lot of important services to improve quality of life, pain control, access to care, linkage to care. And I think sort of rethinking about palliative care and implementing it actually earlier in the
Mm-hmm.
stage of disease, not as a transition to death, but really to help people improve their care and actually transition to health. And I
Mm-hmm.
think implementing it earlier in decompensated patients can actually lead to better outcomes.
Absolutely. Palliative care is not the same as hospice,
Yes.
is the top line message. But I remember learning about it, years after I was transplanted, and I was at a conference and somebody gave it, and I was like, "Ooh, I could raise my hand. I could use some of that now, some of that, coordination and pain management and just, and my family too." And I think particularly it came to mind for me, in these conversations about, less individualistic cultures where the decisions about care really are family decisions, and having conversations with the entire family on how to move forward, or if to move forward, is so important to have, and that these services are available for the entire family, I think is really important message to make sure that Asian Americans and African Americans and Hispanic families are feel that this type of care is for them. Dr. Lee, do you agree that this palliative care can be part of the conversation to serve the entire family?
Yeah, I agree. I think the clinically, so that the palliative care, like at least in our region, and it's I don't think we have enough resources, frankly. So at first, like it's a heavy service on the cancer patients,
Mm-hmm.
but outside the outpatient care for the palliative, it's very limited in our region. So which
Mm-hmm.
sometimes is very hard, especially for
Mm-hmm.
patients with decompensated cirrhosis. Reach the point that they are not a transplant candidate, and then you have to reach the point how we can actually discuss in terms of the patients at this advanced disease. What is the kind of like the goal that it took together, how we can get the best quality of the life that they have probably at the end of that of their life. So it's very important, as exactly as Dr. Wong said. It does not necessarily mean that you're giving up there, you're not receiving any treatment whatsoever. So things may change. So it just kind of like that if the conditions going back, and you will like the patient will kind of like continue to follow up as like the standard care, like in the clinic. But it's just like the thoughts into having this idea and to help the patient to understand what they have and what they are expecting, and understanding their support they can, all the resources they can use and can have, help them to, they are not alone, so on their own to go to kind of like endure is everything. That being said, I do want to mention about the Asian and like the cultures. So it's a, because of the culture does play a role in terms of how people decide on the healthcare and a lot of things. So as opposed to patient-centered care in the Western countries, so a lot of like many Asian cultures prefer family-centered care. So the often people want to have, especially elderly people, they want to have their family get involved and participating in the decision making in terms of their care, especially major decisions such as cancer treatment or surgeries or something like that. So I think that's kind of like the big part, and for the families as well. So for the clinicians, we are able to kind of like discuss about the clinical indications, make sure that we kind of like have the sort of like a practice of evidence-based of medicine, trying to get the most favorable outcomes for our patients. But that is not the only thing, because of when we're talking about delivered health care, it's not just talking about the disease itself. We have to treat the patients and probably their families, and as the whole, that to trying to get everybody kind of like comfortable and to do to make the right decision. Because sometimes the medical decision, if we are just go straight by the line in terms of what treatment that you have, but not necessarily fits everyone. So sometimes people, because of their culture or the culture or religious belief, that they may choose the things that is okay. I want to have minimal invasive things. I just want to have a good quality time that I can spend with my family at the end of my days. So that's, it's kind of like the things that it's important. So in return, in terms of the palliative care in the Asian population, I don't think it's a very well utilized or kind of like introduced to the population, probably because of the cultural issues, and we are more with the family support and to give us the support rather than have a professional group and with the palliative doctors and to talk about the medical conditions.
Dr. He?
Yeah, as a medical oncologist, I just cannot pass this topic. So, we use quite a bit of palliative care for patients at the end of life. But I think there's a lot of, even for people who deliver palliative care, needs education on how to care for patients with end-stage liver disease, liver failure. And we made those education video. The most watched video is how to manage your symptoms of liver failure. That's how much patients watch that video, because you can see most palliative care service, they provide nausea control, pain control, and then in terms of management of liver failure, even under the care of a hepatologist and medical oncologist, day-to-day management, and it still needs a lot of education to the family, to the patients, to the caretaker, even to the people who deliver hospice like palliative care service to them, because it's such a complex medical issue. So I really want to. We had some one group of patients made a mentorship program for a different type of cancer. So patients and family actually put together this mentorship program for other patients and family. I think same thing applies to people with end-stage liver disease, and education is key to how to manage it, because there are a lot of patients don't understand, and they are just, uncertainty is what make people have fear. So I think education is very important. Thank you.
No. I think that's
the point I want to make.
That is great. I was coming to you. And I, on the point of peer mentorship, before we wrap this up, GLI is expanding our peer mentorship. We're training community ambassadors to be able to, provide support overall, particularly on living with a liver disease, different types of liver disease. Digital health skills for anybody who's tried to get on the app and get a vaccine at CVS and things like that. In doing that the other weekend for my mother, I saw many senior patients, many from local Asian communities as well, being turned away because they didn't have the digital literacy to sign on to the app and get their vaccine. So it's something that we want to work with and solve. And the same thing in engaging in clinical trials. And so, part of the outcome is not only building a cadre of peer mentors, but peer mentors and ambassadors that look like the communities that they're serving and speak the languages that they're serving. So more to come on that. So that would be my real last word, less my welcome. But maybe starting with Dr. He and then going to Dr. Lee and then Dr. Wong, what one thing would you want people to know about Asian and Asian American populations and liver cancer?
I think be open-minded to information provided to you. It is very important to screen and screen for disease, and then that's the effective way to prevent cancer. And when cancer is diagnosed, there are now in this country, there are so many treatment options. You want to be open-minded to hear what is available. And it is okay to get a second opinion, to understand how this disease is treated. And I think that you will get the best outcome.
Great. Dr. Lee, your final word to our audience.
Yeah, I think that for being Asian and Asian Americans should be encouraged to advocate for themselves and on the healthcare. So I think this is it's very important. And if we're talking specific for the liver disease, so I would definitely encourage the people who may watch for this video and just make sure that you understand. So try to pursue the appropriate screening tests if it's needed, not necessarily just when you become symptomatic, which is probably not going to be good enough.
Excellent. Dr. Wong?
Yeah, no, this has been great. And I would say my takeaway is, we've had made big strides in Asian American health with respect to liver disease and HCC, improvements in hepatitis B treatment, declining HCC incidence. But I would challenge those, especially at the policy level, not to be complacent and not to be satisfied with what we have done, because there's still so much we need to do. And we've highlighted that in the past, hour and a half. And I think there needs to be a renewed interest, renewed enthusiasm. And as we sort of discuss, sort of expanding and take a more comprehensive approach and ask ourselves, what else can we do? And how can we challenge those that can make decisions at the policy, at the health system level, to really incorporate everybody, all the stakeholders, so we can really make effective change.
Well, we will definitely take up that banner here at GLI, but we'll need all your help. That's all of you and everyone listening and watching to this. So I just want to thank my panelists I learned so much today. I took so many notes. I have our marching orders, but I just thank you so much for today.
Thank you, Donna. Thank you for your invitation.
Thank you so much.
Thanks for putting this together. I think this will provide great benefit to the community.
I hope so. And I encourage everyone to watch the other parts of our series and to learn more about our Center for Liver Health Equity and take part in all of the October is for Livers activities. Of course, we believe all months are for livers, but particularly October. Please enjoy on globalliver.org and all of our social sites. Until next time.